What's up, Doc Mike? Public Health on Call. By Johns Hopkins Bloomberg School of Public Health. Today's topic for October 6, 2020. The recovery process of ICU COVID-19 patients. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Our focus is the novel coronavirus. I'm Josh Sharfstein, a faculty member at Johns Hopkins and also a former secretary of Maryland's Health Department. Our goal with this podcast is to bring evidence and experts to help you understand today's news about the novel coronavirus and what it means for tomorrow. If you have questions, you can email them to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, Stephanie Desmond talks to Dr. April Pruski, whose job it is to help COVID-19 patients move out of the intensive care unit and into their homes as quickly as possible. They discuss unique approaches to rehabilitation being used with these patients and some of the long-term impacts of COVID-19 on the body. Let's listen.
Dr. April Pruski, thank you so much for joining me.
Hi, thank you for having me.
So you are a physiatrist. So let's start with the question we might all have is, what is a physiatrist?
So a physiatrist is a special type of medical doctor that underwent training in physical medicine and rehabilitation. We treat patients of all ages, and we really focus on function. So what a physiatrist does is they can determine and lead a treatment plan or a prevention plan to treat the whole person rather than just one specific area. We usually work with a comprehensive interdisciplinary team. We work with physical therapists, occupational therapists, speech therapists, psychologists, all for the goal of helping a patient's recovery to get them back to the things that they enjoy.
And a lot of your work is in the ICU, and you're seeing a lot of COVID patients. Tell me about that recovery process.
So I have been involved in the COVID recovery process with some of my colleagues here at Johns Hopkins, and we've taken a little bit of a different approach to the rehabilitation process. Traditionally, the medical community waits for somebody to recover medically before they're kind of more mobilized and rehabilitated. So the process that we have here at Johns Hopkins is there's a team of physicians in the MICU and in the other ICUs where we've had the COVID patients that daily reviews the patient's medical readiness for therapy. Once a patient kind of looks good, that they're perhaps not being as sedated, they're not being proned, they're not being as heavily ventilated, we ask the team to put in some therapy orders. And then at that time, we have a physical therapist go in and start to mobilize that patient. And the physical therapist kind of looks at things like, how is somebody able to move around in their bed? How are they able to roll? How are they able to sit up? They can progress somebody with their sitting balance and then to standing. Then we also ask an occupational therapist to see a patient. And the occupational therapist has like a very dynamic role where they're looking at how does someone get back to doing their activities of daily living, such as brushing their teeth, feeding themselves, dressing themselves. And also, what does their positioning look like? So maybe providing some splinting to them so that patients don't develop contractures or other unwanted consequences. And then we also get speech therapists involved in the ICU. And for many of the patients from COVID, they have a lot of hoarseness in their voice or dysphonia. And that could be from the prolonged intubation. They have some trouble swallowing. They're having some trouble with their memory and their thinking. And together with that team, we have a rehab doctor who's working with everybody and kind of putting the piece together. So here at Johns Hopkins, we've used an outcome metric called the AMPAC. It's the activity and mobility score of how somebody is doing. And based on that outcome metric, we have kind of categorized different patients. And we have found that there's a group with moderate impairments who benefit from this acute intensive rehabilitation services. And that can start as early as the ICU, where a patient would get a treatment session of PT, OT, or speech, or even all three in one day, to start the rehabilitation as soon as they're ready to start moving around, to prevent what the complications are of prolonged bed rest. And those complications of immobility is muscle weakness that happens. And those muscles, as they get weaker, it's harder to recover. So the sooner we get the rehab on board, the better these patients are able to function. Mm-hmm. And we have found that it starts in the ICU, but then it continues onto the medical wards, and we're able to get many of these patients home without needing to go to a post-acute care. And those post-acute cares are intensive inpatient rehab or subacute rehabs. So we find that doing therapy early can get people home sooner.
Mm-hmm. I also understand you're doing some telemedicine inside the hospital. Can you tell me about that?
That's right. So in a goal of preservation for PPE, as we know that there's many COVID patients and potentially there's not enough gowns and gloves for patients, we have found that with some patients, we're able to communicate with them at their tablet at bedside. There have also been from the rehab department, a deployment of a program called Mind Motion Go, which is a therapy program that patients can kind of do on their own with the direction of therapists and be able to kind of use video gaming in order to improve their endurance and tolerance.
Mm-hmm. So you're saving PPE by doing it over this tablet instead of having someone go into the room and gown up.
That's right. And then some of our services, like psychology services, the psychologists don't have to be at the same campus. They're actually able to communicate with the patients. So, for example, for our Latin community, many of the patients who are Spanish speaking, we are very lucky that within our department, we had a Spanish speaking psychologist, but she wasn't here on site, but she was able to kind of tele-rehab in and be able to communicate over the tablet and work with us as a team.
That's great. You're also using negative pressure. Can you tell me about what that is and what you're using it for?
So in order to have COVID preparedness, we know that we have these patients in a negative pressure areas in the hospital. So we've converted these rooms where there's no flow outside of the hospital, outside of the unit. Flow of air. Yes, to contain the COVID virus within one specific area. So there's usually an area where you don to get inside. And when you don, you're wearing either your N95 or your PAPR hood. And then on the floor, you're constantly protected where you're not taking your N95 off between patients. And that protects from the virus leaving that area. So in the beginning of this COVID pandemic, what we were seeing is that some of the patients weren't able to pass the virus out of their system. Our rehab units here at Johns Hopkins were not able to be converted to negative pressure units. So we were able to actually discuss with internal medicine and let them know that we think that some of these patients need that same level of intensity, that some of them may not be able to get home. And they were able to provide us a few rooms on their negative pressure floor so that these patients can be advocated for and have that same intensive rehab that they would have on a traditional rehab unit. So we were able to give them 3 hours a day of PT, OT, and speech, or some sort of combination there within, so that they could be able to get home without needing to go to another facility.
Mm-hmm. So some of these patients are there a long time, and when they go home, they are not, they're not completely like they were before. They're not back to their old selves again. And is this confusing to the patients, and how are you handling that?
That's a really great question. So I think that many of the patients, when they're in the hospital, they're so excited to go home. And usually our goals are, if you can kind of move around in your own room, you'll be able to kind of move around at your own home. And I think that when some patients get home, they notice that they're a lot weaker than when they left initially. And we see that these patients have limitations in their endurance, that they're very fatigued very easily and they're very short of breath. And I think that there's other surprising things that come up for these patients. Many of these patients have been in the ICU, so they suffer from something or potentially can suffer from something called post-intensive care unit syndrome, which is really like a whole group of different symptomatology that can occur to these patients. So they can have cognitive symptoms where all of a sudden they go home and their memory isn't the same. They have thinking problems, they have difficulty talking, they have forgetfulness, concentration difficulties, they can't really problem solve. They suffer from post-traumatic stress disorder, where they're kind of having these unwanted memories and they're intrusive and they have anxiety, depression. And then, of course, the physical symptoms that they're experiencing of overall muscle weakness, fatigue, decreased mobility, and just like some trouble sleeping in general and insomnia. And I think that is very surprising because when you think that you're leaving the hospital, you feel like maybe I'm going to be out of the woods, but it really requires the interdisciplinary team that we have in the hospital to continue outside the hospital. And I think it's also very important to mention that it's really not just the patient, it's their family. And a lot of these families also have emotional and mental symptoms from their family member being in the hospital, not being able to communicate, not being able to sit by their bedside when they're ill. And they have a lot of post-traumatic stress disorder and grief and changes in their own sleep patterns.
Mm-hmm. Are we seeing a lot of permanent damage from COVID? I know I did read about a young person having to have a lung transplant as a result of her COVID.
Right. So I think that we're still learning a lot about COVID. And what we do know is that coronavirus is not just a lung disease, but it's really a multi-systemic dysfunction and sometimes failure of those systems as well. That it really can affect your lungs, it can affect your kidneys, your brain. You can get clots in your bodies like deep vein thromboses. Sometimes the clots can be inside of your brain and you can get a stroke. And it's just very ravaging to the body. And it can be so ravaging to the point that there was that patient who needed to go and receive a lung transplant because she wasn't able to function without it. And I think that even those patients, even after they need the lung transplant, there is a lot of rehabilitation that needs to go in and a lot of work to get back to some sort of functioning within the community again.
Mm-hmm. How is this recovery process different from other recoveries that you see in the ICU? I mean, it feels like these folks are sicker longer, perhaps, and I'm wondering if the recovery process is different.
So that's actually a very interesting question. And I think that it depends, because I think that what I've seen is that a lot of healthy people were also sick. And those healthy people actually had some sort of reserve beforehand. So they would look really bad one day. And what I would mean by that is that they would require like a total amount of assistance of like a physical therapist and occupational therapist. But then like the next day or two, all of a sudden they would regain a lot of their strength. And with that intensive therapy that we were providing them, they were able to recover a lot faster. And I think that in prior ICU patients, what we would see is that they were very sick. They were sick in the ICU for a very long time. They have a lot of comorbidities and underlying medical problems. And we were just not really able to rehabilitate them as quickly. So I've seen kind of the opposite of like people actually recovering a lot better. I suspect that the reason the patients are recovering a lot better with us here at Hopkins is because we've flipped rehab. We're rehabilitating from the beginning. We're standing shoulder to shoulder with the intensivists and with the medicine doctors, intervening as soon as we can.
Is it also because some of these patients are younger and this is the only thing wrong with them?
That's right. Yes. And I think that once we can help build up their reserve and do strength training activities, and I think that the other thing is also delirium happens very frequently for the ICU patients. And one of the things that's very helpful for delirium is setting a schedule, and having these daily therapies help somebody set that schedule. And then they're able to recover a little bit more quickly from their delirium as well.
Mm-hmm. And we're all having trouble with schedules, you know, even those of us who are perfectly healthy staying home. I mean, time passes in a whole different way these days.
Yeah.
And I think obviously it's a much more serious thing in the ICU.
Absolutely. Absolutely. And I think that it's hard in the ICU because you're being monitored so closely that everybody's checking in on you. They're checking vital signs every hour. And then, in rehab, we're like, okay, we want you to sleep at night and be awake during the day. And every patient says to me, well, how can I sleep at night if someone is coming in here every single hour and waking me up and asking me, how do you feel? Are you doing okay? Move your arm, move your leg. So it's usually we see that the delirium ends up resolving when they go to a general medical floor because there's less frequent checking on the patient through the night because you're less critically ill. So we see that the delirium does recover.
Mm-hmm. Well, April Pruski, thank you so much for your time.
Thank you for having me.
Thank you for listening to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Please send questions to be covered in future podcasts to publichealthquestion@jhu.edu. This podcast is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Lamare Morales. Audio production by Niall Owen McCusker and Spencer Greer, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.